Okay, well, can everyone hear me? Yeah. So I think I see most of you have your lunch, which is the most important thing, and I want to welcome you on behalf of the program to this symposium on managing hyperkalemia and heart failure, implementing strategies to reduce patient risk. I'm Akshay Desai from Brigham and Women's Hospital in Boston. I was just in the last session with you, for those of you who are here, and I want to introduce Nancy Albert, who's the Associate Chief Nursing Officer in Research and Innovation and a clinical nurse specialist in the Kaufman Center for Heart Failure at the Cleveland Clinic. Next to her is Stephen Green, who's Associate Professor of Medicine from Duke University and Duke Clinical Research Institute in Durham, North Carolina. And then further on down the pike, dressed very nattily, is Robert Page, the professor from the Departments of Clinical Pharmacology and Physical Medicine at Skaggs School of Pharmacy and Pharmaceutical Sciences at the University of Colorado, Anschutz campus in Aurora, Colorado. So our focus today is on strategies for management of hyperkalemia and to enable renin-angiotensin system inhibition. We want this to be engaging and fun, so we will have some didactics. We'll start with a talk broadly about hyperkalemia and risk in heart failure and its impact on RAAS inhibitor discontinuation. We'll then talk about ways in which to mitigate the risk of hyperkalemia, and then we will focus on cases that sort of crystallize how we might implement some of this work in practice, and we'll leave ample time for your questions at the end. So I have a few announcements before we get started with the meat of the program. First, I want to thank AstraZeneca Pharmaceuticals for providing an educational grant to support the program, and thank Vox Media for sponsoring the symposium. Before we begin, I want to make sure you complete the pre-symposium questionnaire. So if you have them on your packet, do that right now, and people will come around to collect them after you are finished. To receive credits for the CME or CNE afterwards, please complete the evaluation form that's on your seats and return it to the staff at the end of the meeting. Please see the faculty disclosure information in the handout because we won't go through that in every talk. Representative slides from all the talks are included in your handout, and many of the speakers, I'm sure, would be willing to share specifics if you need them. Presentations may be viewed later on cmeplanet.com. Question cards are being distributed if you would prefer to write out questions. We're always thrilled if people are willing to come up to the mic so we can see your faces, but I realize not everyone shares my penchant for standing in front of people. To be made aware of future program, follow CME Planet or at CME Planet on Twitter and other social media. And as we get started here, please turn off all your electronic devices or move them to silent mode. Don't want any ringing or beeping if we can avoid it. That might interrupt the flow of the program. So with that introduction, I want to get started with the substance of the program, and I'm going to bring Stephen Green up to talk to you about hyperkalemia and risk in heart failure, recognizing the impact on RAAS inhibitor therapy. So, Stephen.
All right, thank you, Akshay. And first of all, I just want to say it's my real pleasure to be with everyone this afternoon. This is one of my favorite conferences of the year, so I hope everyone else is enjoying it as much as I am. So I'm going to be talking again about hyperkalemia and risk in heart failure, recognizing the impact of RAASi therapy, discontinuation, and dose reduction. So the first thing to understand is let's first think about HFrEF. ACE, ARB, ARNI, and MRA are obviously really important. And it's not just that they're a little bit important, again, really important. You look, for example, back at some of our older trials now, the consensus study with enalapril versus placebo, RAAS with spironolactone versus placebo and HFrEF. The drugs just weren't barely positive. They weren't positive for, some of the component endpoints. They reduce all-cause death, the endpoint of all endpoints in HFrEF. And again, they did so by a wide margin. And then it's not just that we should use these therapies, we also need to try to use them at the guideline recommended target dose. And we need to do this for really two reasons with our RAAS inhibitors. So one is that no trial just said, here's initiation of 5 milligrams of lisinopril and just leave it alone and follow patients. They all had gradual, tolerance-limited, protocol-specified up-titration in the protocol. So again, if you want to follow what they did in the trial, you need to try to up-titrate to the maximally tolerated target dose. But also, with our RAS inhibitors, ACE and ARB, we also have direct randomized controlled trial evidence that, again, randomized patients to lower dose versus higher dose. And guess what? Higher dose was better for hard clinical endpoints of death or heart failure hospitalization. So again, it's not just to use these drugs, but to get the maximum benefit, we need to up-titrate maximally tolerated or target dose. But despite what I would call an overwhelming body of evidence, we know when we look at the real-world data, we see major gaps in the use of our RAS inhibitors and MRA. These are data from the CHAMP-HF registry for outpatients with heart failure with reduced ejection fraction. You look at the people that are on the target doses of these therapies, only 1.5% were on the target dose of ARNI, 8.5% on the target dose of ACE or ARB, and 22% on the target dose of MRA. So despite, heart failure having a prognosis comparable to many forms of cancer, despite these drugs reducing all-cause death, we have a major problem with getting these drugs in the target dose to our patients. But that's all HFrEF. Well, what about HFpEF? Well, we now have data presented last year from the Fine Arts HF study, which really established non-steroidal MRA as really a pillar of therapy for heart failure with mildly reduced or preserved ejection fraction. Fine Arts HF, finerenone versus placebo, definitively positive clinical trial for the primary endpoint of CV death or total worsening heart failure events. So we'll see what the guidelines say when they get updated, but again, in my opinion, finerenone is now a pillar, a definitively proven therapy for improving outcomes in HFpEF. Well, that's efficacy, but now what's the other side of the coin? Safety. And as good as MRAs are in improving hard clinical outcomes and quality of life, the thing that we all have in the back of our mind is the risk of hyperkalemia. And whether you're looking at the HFrEF trials or the HFpEF trials with TopCat, with spironolactone, or Fine Arts with finerenone, you see a 2 to 3-fold increased risk of hyperkalemia when we have MRA compared with placebo. So the risk is real in the clinical trials. And when we think about, well, what are the patient phenotypes or the predictors that are going to forecast a downstream hyperkalemic event? Well, there's been several analyses that have looked at the independent associations with downstream hyperkalemia. This is one of the more recent ones, secondary analysis of Fine Arts HF. And you can see here the things that are independently associated. The couple that I'll highlight is worsening kidney function, dedicated here by the creatinine or the UACR, also type 2 diabetes. Also higher NT-proBNP, a marker of more advanced heart failure, also seems to be independently predictive of downstream risk hyperkalemia. And I just mentioned kidney function, whether you're looking at the creatinine or the UACR as one of the most important predictors of downstream hyperkalemia risk. Well, the trouble thing with that finding is that CKD is all over the place when you're looking at heart failure patients. And these are data from Get With The Guidelines Heart Failure, which is a hospitalized for heart failure registry nationwide in the United States. We see that more than 2 in 5 patients discharged from the hospital for heart failure have an eGFR less than 45. And then even 3 out of 5 have an eGFR less than 60. So the majority of the patients that are going home from a US hospital for heart failure have underlying CKD. And we all know that having CKD along with heart failure is worse than having heart failure alone. But one of the mechanisms driving those worse outcomes with comorbid CKD is what I call the risk treatment paradox. So as eGFR declines, so too does the likelihood of getting RAASi and MRA therapy. And again, there's this risk treatment paradox. The patients who you could argue need the therapy the most are less likely to get it as their kidney function declines. So that's kind of setting the stage for how important our RAS and MRA therapies are in heart failure. But now let's think about hyperkalemia specifically. How common is hyperkalemia in our patients with heart failure? So there's plenty of data out there to suggest it is very common. These are data from the United States for Medicare patients looking at the 1-year prevalence of hyperkalemia across different common conditions that we see all the time in practice. Well, again, silver medal for the most common hyperkalemia prevalence goes to heart failure, just behind CKD, almost a 10% prevalence of heart failure if you follow, of hyperkalemia if you follow heart failure patients for a year. And that's US data. Well, what about other parts of the world? So here's an analysis that was taken from Sweden, looking at heart failure patients across the spectrum of ejection fraction. You follow them forward for 1 year. What's the downstream risk of hyperkalemic events? You see if you define hyperkalemic event as a potassium greater than 5, you see about almost a 25% chance of hyperkalemia. 5.5 is your threshold. Again, you have about a 1 in 10 chance of getting a hyperkalemic event. And that's regardless of ejection fraction. So again, hyperkalemia is very common for our heart failure patients. But the other clinically relevant thing to take into account when you're looking at these real-world evidence is that once someone has one hyperkalemic event, it often happens again and again. They're not generally isolated incidents. And this is just one big real-world data source that came from Denmark that followed over 30,000 patients with heart failure, mean follow-up of 2.2 years. About 4 in 10 had at least one hyperkalemic event. But then, again, once they had the first hyperkalemic event, you continue following those patients. Took only a median follow-up of 6 months for the second hyperkalemic event to develop. And then again, you see gradually shorter intervals. And again, once you have it one time, you tend to have it a second or a third time. Let's think about patient outcomes after hyperkalemia. So there's this U-shaped relationship when we think about our cardio-kidney metabolic conditions and their serum potassium level for their mortality risk. The nadir of risk seems to be around 4.5 or so, but as serum potassium gets lower or gets higher into the hyperkalemic range, again, you see steady incremental increases in the risk of all-cause death. And then again, this is for all the cardio-kidney metabolic, but again, the patients who have that overlay of, let's say, heart failure, CKD, and diabetes, which is actually really, really common, those patients have the biggest price to pay with mortality if they have a hyperkalemic event. When we think about, well, what is the mechanisms driving those worse outcomes with hyperkalemia and heart failure? One thing driving those worse outcomes is that hyperkalemia tends to make us withdraw our life-saving RAASi and MRA therapy. These are data from the Qualify registry, which is a real-world registry from Europe from a few years ago. And they looked at their patients who were deemed as not tolerating ACE inhibitors, ARB, or MRA. You see here, specifically for MRA, about 30% of the time the patient was deemed to not tolerate MRA was specifically because the clinician reported concern over hyperkalemia. And again, you see it also contributed to the reasons for intolerance to the ACE and ARB therapies. And then when we look at discontinuation rates in the United States, after you start these therapies, as hard as it is to overcome that initial activation energy to get these patients started on therapy, they don't tend to stick. And these are data from CHAMP-HF, which show the discontinuation rates from the time these therapies are started. You see, if you follow patients for 18 months, more than a quarter that were started on an MRA discontinued. And you see a lower but still substantial rate of discontinuation for ARNI and ACE and ARB. And again, thinking about other parts of the world, these are data from Sweden showing that when you had over 13,000 patients in this SCREAM registry of new MRA starts, followed them for a year, about almost 1 in 5 developed a hyperkalemic event. But then what happened to medical therapy after that hyperkalemic event? Look at the blue MRA discontinuation rates and the red with ACE-ARB discontinuation rates. Even mild hyperkalemia gave you more than a 4 out of 10 chance in real-world practice of seeing the MRA discontinued. And the other concerning finding is that these aren't generally temporary discontinuations. Once someone has a hyperkalemic event and discontinues their MRA, for example, it tends to stick with that patient. It usually means permanent discontinuation. So again, these hyperkalemic events set the course of GDMT, not just in the short term, but unfortunately also stick with the patient for the long term. But then also looking at the association of RAASi discontinuation with hard clinical outcomes. This is US data from a real-world data set called Humedica, which looked at heart failure patients and their mortality risk described by whether they stayed on target dose, down-titrated the dose of RAASi, or discontinued the dose. Again, you see that the lowest, the blue color, that's the mortality risk for target dose. And again, it goes exponentially up when we have de-escalations or discontinuations. So the last slide to sum it all up, when we think about hyperkalemia and the risk in our heart failure patients, we need to understand that hyperkalemia is common among our patients with heart failure, and that once it happens one time, it often happens again. And then we need to understand that risk of hyperkalemia, both the real risks, but also the perceived risks and the fear of hyperkalemia. It really complicates heart failure management. It's a frequent barrier to initiation and up-titration of RAASi and MRA therapy for heart failure, and it's a frequent reason for RAASi and MRA discontinuation. And lastly, we need to understand that dose reduction or discontinuation of RAASi and MRA is associated with worse outcomes in patients with heart failure, and that we need strategies to better enable persistence of these medicines among our patients with or at high risk for downstream hyperkalemia. So with that, thanks very much for all the attention.
Great. So as we're, thanks, Stephen. That was outstanding and actually very beautifully and expertly sets up this next talk, which is really, now that we understand the importance, prevalence, and consequences of hyperkalemia for our patients with heart failure, how do we begin to tackle the problem of managing it in a way that doesn't compromise outcomes for patients? So as the slides come up here, we'll delve into that. Do I need to? Oh. Look at that. There. All right. So these are my disclosures. There are 4 real goals here for this next talk. The first is to talk about conventional strategies for management of hyperkalemia in patients with heart failure other than stopping the medicines that may be contributing to risk. The second is really to review some of the data supporting the role for novel potassium binders in the management of patients with hyperkalemia and heart failure. I want to talk a little bit about emerging data supporting the use of potassium binders to enable RAS inhibition in patients with heart failure, and then talk about some of the safety concerns that might attend use of those agents as well. So I like this slide because it really reflects what we all do in clinical practice every day, and I think we can all imagine being the genderless person on the left of the slide who is trying to decide what to do when the potassium goes up. And there are a lot of questions in that bubble. One is really, do I need to do anything at all? How high is the threshold that should trigger action? And then, is there something I can do that won't affect the medicines I'm treating that I can do? Can I take away something, a potassium supplement or a non-essential medication? Should I think about a new agent like a potassium binder? Should I modify the diet? Should I stop life-saving therapy? Should I just ask the nephrologist? There are a lot of options, and we have to engage all of these options with our patients in the clinic setting. So these are sort of 4 of the paradigmatic approaches to managing hyperkalemia in the clinic. One of them is to tell patients to take in less potassium. And I think all of us have told patients, oh, you're eating too many bananas, or stay away from the licorice. But, not that much. You have to eat, it turns out, many, many inches of banana before you can generate hyperkalemia. And most people are pretty efficient at excreting dietary potassium unless kidney function is very poor. And it's very hard to adhere to a strict low potassium diet. And imagine that low potassium diet then layered on a diet for a patient with diabetes, or a calorie restricted diet, or a vegetarian diet. It's just very difficult. And then patients can have side effects from that approach, including constipation. And there may be competing interests in diet. We might be trying to restrict sodium, which makes it hard to restrict potassium. We often give loop diuretics to our heart failure patients, and that certainly lowers potassium and may be a strategy, but the effect of diuretics depends on renal function. There are side effects to intensification of diuretics, including gout. And these agents we know in high doses can actually do exactly what we hope to avoid in heart failure patients with low EF, which is activate the renin-angiotensin system. I think Stephen has nicely laid out to you the problems with RAS inhibitor discontinuation, so I won't do that. I won't talk specifically about that, but we know that this strategy is associated with high CV risk. And then our traditional strategies for binding potassium were sodium polystyrene sulfonate, which is really an agent that was developed for acute management of hyperkalemia. When it's used in clinical practice, it's difficult to imagine giving more than a few doses because doesn't taste very good. It has a hard, gritty texture. When patients take it, they don't feel well. They sometimes have nausea and vomiting. It irritates the stomach. And in chronic use or in use at high doses, in some patients, it's been associated with risk for intestinal necrosis. And so it's certainly not an agent that we would like to give in chronic application for patients. It's really just an acute therapy for hyperkalemia when we need to treat it in the emergency department. And there's no data about long-term efficacy and certainly no data about using this agent as a way of mitigating risk with heart failure therapy. As I mentioned, the other challenge in managing hyperkalemia is when we should worry. I think the guidelines here from different organizations that have attended this question are really summarized on the slide. The x-axis here is the potassium threshold that should trigger a change in your dosing of RAS inhibitors, and then the y-axis is the potassium level. And you can see that some organizations, including the AHA and ACC, have been pretty conservative and say anything over 5 is not a great idea, should back off. Others have been a little more bold and said maybe 5.5 or even 6 is okay. And when we talk to our nephrology colleagues, they scoff at the fact that we worry about mild elevations in potassium, particularly if renal function is intact when it goes above 5. We're too fearful, they say, in our clinical practice. But what we also can do is think about ways in which to modify heart failure therapy in order to mitigate hyperkalemia risk. And there's evolving evidence that some of our newer guideline-directed medical therapies, particularly when optimally sequenced, can help to mitigate the risk of hyperkalemia. This is data that we published some time ago from the Paradigm-HF trial, highlighting that in this trial, randomizing patients to ARNI versus ARB, that those patients who got MRA during the trial on the background of an ARNI actually had lower rates of incident hyperkalemia than those who got the MRA on the background of an ACE inhibitor, suggesting the neprilysin inhibitor component of this drug may help to lower the risk of hyperkalemia during MRA therapy. And that might suggest that sometimes in a patient at risk, you might want to sequence the drugs so that the MRA follows on the initiation of the ARNI. We also have data about SGLT2 inhibitors, which we know in both Emperor-Pooled and in DAPA-HF reduce the risk of incident hyperkalemia compared to placebo. It's a little unclear precisely what the mechanism is here, but there may be some diuretic effect that may contribute to this reduction in risk. But again, regarding the rationale for early introduction of SGLT2 inhibitors in patients with heart failure and reduced EF to enable MRA therapy. And now, because of the data that Stephen showed you, maybe the same strategy would obtain in patients with higher ejection fraction who require a non-steroidal MRA, because that risk of hyperkalemia does persist. So when we think then about alternate strategies, we really then move to adding on therapies to the regimen that may help to lower potassium in order to enable continuation of MRAs and RAS inhibitors. And that's a strategy that may seem a little bit odd, giving another medicine to treat the side effects of one, but it's something we do in cancer therapy all the time, which is to treat nausea and to we know chemotherapy might cause nausea, but we give antiemetics along with it. Many patients get ondansetron to treat nausea from chemotherapy, and we accept that. So similarly here, if we know we have an effective therapy, maybe the strategy should be to simply mind the side effects. So we have two strategies here that are available. One is patiromer, the other is sodium zirconium cyclosilicate. The structure of these compounds is slightly different. The patiromer is a non-absorbed cation exchange polymer that has a calcium sorbitol counterion. These are exchange resins, if you will, so you trade the potassium for a different cation, and in the case of patiromer, that's calcium. In the case of sodium zirconium cyclosilicate, it's divalent cations like magnesium, but also sodium and hydrogen. There is a slight difference in the onset of action. The onset of action is a little quicker for SZC than it is for patiromer, and there's a slight difference in the drug interaction tendency. where there's known drug interaction with bisoprolol, carvedilol, telmisartan with patiromer, and the drug is labeled to be administered not within 3 hours of the start of medicines to mitigate the risk of drug interactions. SDC doesn't have as many established drug interactions, but it does transiently increase gastric pH, and there are theoretical interactions with a whole bunch of drugs that have pH-dependent solubility. They also look a little different, and mouth feels a bit different for the two drugs. So there are some differences to keep in mind, and I'll show you data about efficacy for both. So the early data about efficacy for patiromer is from chronic kidney disease populations in patients who are treated with renin-angiotensin system inhibitors. Here are not MRAs, mostly ACE inhibitors and ARBs, who develop hyperkalemia, and here are the thresholds of potassium more than 5. And in the OPAL HK trial, looking at short-term effects of patiromer in this hyperkalemic CKD population, you can see that introduction of patiromer was associated with rapid reductions in serum potassium levels of about a milliequivalent per liter, so a substantive reduction that was dose-related that persisted during the duration of patiromer exposure. And then following on this short-term single arm, there was a randomization to withdrawal of patiromer or continuation of patiromer. And in that experience, you can see that the patients who were withdrawn from patiromer ended up having more RAS inhibitor dose adjustment or discontinuation. And the number of patients at the end of the study who remained on a RAS inhibitor was much higher in the patiromer arm. We now have also longer-term experience in the CKD population from Amethyst diabetic nephropathy trial. This is a diabetic population with kidney disease who are hyperkalemic, again getting patiromer, but now for a much longer duration exposure. And you can see that chronic exposure doesn't attenuate the treatment efficacy, and you have maintenance of normal kalemia for an extended duration of time until you stop the drug at 1 year, which is week 52 on this slide. And then as you withdraw the drug, predictably the potassium goes up. And pay attention to that tail, because it really does tell you that as long as you're on these drugs, if you advance the doses of RAS inhibitors, that you've created a bit more background risk for the patient, and the importance of maintaining that binder becomes even greater, so because when you withdraw the binder, the potassium goes right back up. We also have data in heart failure with patiromer for prevention of hyperkalemia. So now taking patients who are optimized on RAS inhibitors and who are about to initiate an MRA, randomizing them to treatment with patiromer or placebo, and then dose titrating an MRA in a protocol-directed fashion towards a target of 50 milligrams daily. And you can see that on the patients who got spironolactone titration on the background of patiromer had less hyperkalemia and were able to get to higher doses of spironolactone than those patients on placebo. And this is the strategy of enabling MRA therapy in patients who might otherwise be at risk for hyperkalemia with the background of a potassium binder. And that strategy has now been evaluated in a longer-term clinical outcomes trial called DIAMOND, in which patients with heart failure, reduced ejection fraction, and hyperkalemia, or a history of hyperkalemia, went through a run-in period during which patiromer was added and RAS inhibitor doses were optimized, and then randomized to withdrawal of patiromer or continuation of patiromer. You can see that in those who had the patiromer withdrawn, potassium levels rose, and there was more hyperkalemia, lower dose of MRA, and more hyperkalemia-associated morbidity. And RAS use in general was higher in those allocated to the patiromer group than those in whom patiromer was withdrawn. Again, a strategy for global enhancement of the RAS inhibitor regimen, including MRAs, with the use of patiromer in the background in a population that's known to be at high risk. Now, swapping over to the alternate compound, sodium zirconium cyclosilicate, or SZC, we have data initially from the HARMONIZE trial, which showed that in a hyperkalemic population across a broad range of disease entities, CKD, heart failure, there's rapid correction on administration of SZC. Within an hour, the potassium starts to come down, and by 3 hours, you essentially have a significant peak effect. And then in chronic application, there is maintenance, and when you look at the maintenance phase where there is randomization to different levels, there is dose-related reduction in serum potassium that persists during the chronic application period, and then again, as you withdraw the drug, the potassium goes back up. And when we look at the efficacy across different strata of RAS inhibition at baseline, it's entirely consistent. Nearly all patients are able to normalize serum potassium on RAS inhibition with this drug and maintain normal kalemia during the course of clinical follow-up. Here's another longer-term study looking at maintenance therapy with with SEC in patients with hyperkalemia and chronic kidney disease. And in this long-term follow-up, you can see that 74% of the patients on RAS inhibitors at baseline were able to maintain their dose. A large fraction of those had a dose increase, and only a small fraction, 10%, really had discontinuation. And there were a lot of new patients who couldn't get a drug before because they were hyperkalemic, who were newly initiated on RAS during the study. So based on that accumulated data set, this is what our guidelines in 2022 had to say about use of potassium binders. A 2B recommendation, which, as I heard it from Mike Felker, is might could do, which is not should do, but might could do. That is, your potassium is, you might consider it in a patient who you're going to give a renin-angiotensin system inhibitor, a relatively weak recommendation, but a recommendation nonetheless. So since that publication, we have additional randomized data from the RAASi case trial that was just published. This is a population of heart failure with reduced ejection fraction, symptomatic, optimized on guideline-directed medical therapy, accepting mineralocorticoid receptor antagonists, and either hyperkalemic at entry or perceived to be at risk for hyperkalemia based on risk factors like CKD and diabetes. And in that population, the strategy was an open-label run-in where patients who were hyperkalemic were given SCC to normalize potassium and then dose titrated or initiated on spironolactone, titrated to a maximum dose of 50 milligrams daily. And then in the normal kalemic cohort, the spironolactone was started first, and then SCC was initiated as needed to mitigate hyperkalemia. And in those patients who were on SCC and normal kalemic at the conclusion of the run-in, there was then a randomization phase in which this SCC was either continued in addition to the spironolactone, or the SCC was blindly withdrawn, and then patients were continued on the spironolactone, and then patients were followed for 6 months with a check of serum potassium 6 months after the drug was, 7 days after the drug was stopped. During the run-in period, we learned a fair bit about this perception of risk and this fear of hyperkalemia that Stephen talked to you about. The prevalent hyperkalemia cohort, that is the patients who had a high potassium when they went in, most of them within 48 hours had normalization of their potassium to less than 5 by the time with initiation of SCC. And after 4 weeks, most patients were able, 70% were able to get to the 50 milligram dose. The interesting group, I think, is this high-risk group with hyperkalemia. So these are patients that you and I, seeing in clinic, would say, I'm not sure about Spiro, because the potassium's a little high, they have diabetes, their EGFR is low. But look what happened in that population. Of those patients the clinician thought was at high risk for hyperkalemia, when they started the MRA, because they were normal kalemic at baseline, 80% of them actually did become hyperkalemic. And that suggests that your clinical sense that somebody's at risk is not far off. 20% didn't, by the way. So the fear of hyperkalemia isn't the same as the development of hyperkalemia, and we should try. But if you're worried, you're probably worried for good reason. But again, those people could be corrected with SCC. This is the baseline characteristics of the population. It's an older population that's predominantly male and predominantly, in this case, white. About half of the patients had a prior hospitalization. It's predominantly a class 2 population with the minority in class 3 or 4. It's a low EF population by design, and the serum potassium, as you can see, based on the inclusion criteria, was quite high at baseline. This is the mean potassium is 5. And I think we're very proud in this trial of the background medical therapy, which is about as good as we've seen in any randomized clinical trial. 62% of patients on an ARNI, the balance on some other RAS inhibitor, 95% on a beta blocker, and 72% on an SGLT2 inhibitor. And about 75% of the patients on the day of randomization had gotten to the 50 milligram dose of spironolactone. So this is a pretty robust GDMT-treated HFrEF class 2 population. Note the BNPs, because we're going to come back to that. The SCC group despite randomization, went in with slightly higher natriuretic peptides, slightly lower EGFR, and a much higher dose of loop diuretics. And I'll come back to that point in the back, because it looks like the group, despite randomization, may have been a little bit sicker. So primary endpoint in this trial, remember, we're looking at the incidence of normal kalemia on a dose of spironolactone more than 25 milligrams daily without the need for rescue therapy. That's the composite. And those patients who remained on SCC were much more likely to achieve the composite, 70% of them did, relative to those in whom the SCC was withdrawn, which was about only a third of those patients were able to stay on Spiro at the target dose and maintain normal kalemia without rescue therapy. So a fourfold improvement in the ability to remain on an effective dose of the MRA. And if you excluded the high-dose SCC patients or used a different threshold to define hyperkalemia, the story is basically the same. And a lot of secondary endpoints, including the time to onset of hyperkalemia, the time to discontinuation of spironolactone, other definitions of normal kalemia, all of these things favored the SCC group, suggesting that really there's compelling evidence here for enabling MRA therapy with SCC, and quality of life was not statistically different between the groups. Safety is the key issue from this trial to look at, because although there was no difference overall in the number of adverse events in the patients allocated to SCC versus placebo, or in the number of AEs or SAEs leading to study discontinuation, there was a peculiar increase in the edema-related SAEs, which favored, or I guess you could say were more prevalent in SCC than they were in placebo. Also, the generic cardiac failure SAEs reported by investigators and coordinators was 12 to 4 in favor of placebo. And the number of formally adjudicated edema events based on the completion of edema questionnaires, which were systematically collected in the study, again favored placebo with 22 events in the SCC arm and 16. So there's a suggestion of more congestion in the SCC group and more edema-related events. And remember, this count is a binder that exchanges potassium for sodium, and so there's some questions to whether the sodium retention effects of the drug might have translated into these outcomes. Now, it's important to contextualize this. All the cardiac failure events resolved or were resolving by the end of the study. There were no differences in other parameters of worsening heart failure, like body weight, loop diuretic, or NT-proBNP between the groups at 6 months. And the majority of imbalance of the heart failure events, the cardiac failure SAEs, was in those patients who had a super high NT-proBNP at baseline, which was, as I showed you, more common or more likely to happen in the patients allocated to SCCs. So it's unclear whether this is related principally to those patients who went into the study with more severe heart failure, who are disproportionately represented in the SCC group, but nonetheless, there's biologic concern about the mechanism and whether it may have contributed to some worsening edema. So the take-home messages here are that many patients with heart failure who are at risk for hyperkalemia can safely tolerate MRAs and RAAS inhibitors, but the use, and particularly they can do so if we do it with appropriate steps to mitigate the risk of hyperkalemia. The usage of SGLT2 inhibitors and ARNIs may mitigate the risk of hyperkalemia with MRAs. Those who develop hyperkalemia on MRA therapy might be managed with the use of potassium binders in order to enable MRAs based on the data that I've shown you, although the guidelines have not yet embraced this approach. If you choose to do this, recognize that some patients with more congestion or more severe heart failure may be at risk for worsening edema events or volume retention events with the use of SCC. And it's a little unclear whether this means that we should decongest patients first before starting SCC in particular, or in those patients with more advanced disease, preferentially use the alternative agent, which has a different exchange counterion. And then the other thing to remember is that when you stop these drugs, the potassium goes right back up within a very short time interval, and so adherence, particularly if you've used the drug to enable MRA therapy, is critically important, and we need to educate our patients about this. So with that, I'll close my prepared comments and hand it over to Nancy and Robert to go through some cases.
All right. could bring up the slides, that would be great.
Oh, do I have, did it? Yeah, sorry.
Oh, there we go. All right. So this is a case presentation, and I will have some questions. Let me just ask outright before we get started, how many of you in the audience have used potassium binders previously? I'm seeing a lot of hands go up. Usually when I ask that question, I see maybe one or two, so we've got a very informed audience here. You may want to shout out some answers as well. So this is our real patient, a 74-year-old male, non-ischemic cardiomyopathy, and he's actually had HFrEF since 2023. Initially, his EF was 20%. He had severe pulmonary hypertension, and his right ventricular systolic pressure was quite high at 76. It turned out on MRI he had no reported intracardiac thrombus. He did have an ICD placed in November of 2023. And you could see his history. He had a non-obstructive coronary artery disease, obviously pulmonary hypertension. He does have paroxysmal atrial fibrillation, hypertension, hyperlipidemia, obstructive sleep apnea, and he has prostate cancer, and he is status post radiation. Does this sound like maybe a typical person that you see in your outpatient clinic? He lives 3 hours away from us, so I will tell you that. He lives in a rural area, so a lot of our visits are virtual, not always live. So for those of you that are doing telemedicine, this may ring home to you. His current health status isn't so bad in terms of some things. He has no chest pain, no skipping or irregular heartbeats, no dyspnea at rest, no coughing, no paroxysmal nocturnal dyspnea, no unintentional weight gain or loss. But he tells me all the time he doesn't weigh himself very often. But he does have shortness of breath with activity. He cannot climb one full flight of steps without either taking a break or really slowing his movement. Usually he tells me he slows down. And he does become easily fatigued. He takes a nap almost every day, and that's been going on for over 3 months now. He tries to make it less than 45 minutes so he could sleep at night. He has occasional dizziness. It may occur, it may last, it started 3 weeks ago from the last time I talked with him. So you could see back in March his vital signs were okay. His heart rate was 64. His BMI was not obese. He's 28.71, but he was in functional class 3. And you could see some of his labs here. He's got a little bit of fluid on board. His sodium was only 135. His potassium at the time was 4.9. Oh, I'm sorry, this is 1024. This was previously when I saw him. You could see in March when I saw him, his potassium was now up to 5.4. He still obviously had some extra fluid on board. His sodium still was a little lower than expected. BUN was okay, creatinine not so bad. eGFR was okay in this case. Hemoglobin and hematocrit were fine. His NT-proBNP went up from October 24 to March of 2025, and his PSA after his prostate troubles was in an okay range there. You could see his most current echo, which was done in November of 2024. His EF was 35%, so it had come up from that initial earlier 20% when he was first diagnosed. And you could see a little bit more about his right ventricular systolic pressure and his right atrial pressure. He does have some regurgitation, MR being the worst one. It was 2+ previously, but then it went down to 1+ more recently. So this was his X-ray, and again, you could see his ventricular rates fine, his QTQ and QRS levels you could see here, and you could see the curly B lines. So these are his current drugs. He's on lisinopril 20 milligrams a day, metoprolol succinate 25 milligrams per day, spironolactone 25 milligrams. He's only taking a half a tab per day, simvastatin, aspirin. He's taking over-the-counter calcium, magnesium, zinc, and vitamin D3. So we did some diuresis for that hyperkalemia, and he was started on SCZ. We gave the dosage that you see in the research trial. So this was real live, so 10 grams. He had it 3 times a day for less than 48 hours, and then we just checked his potassium, and once it was normalized within that 48 hours, we switched him to daily. And then once he was on daily, he was up-titrated on his spironolactone to 25 milligrams a day. Lisinopril was switched to sacubitril valsartan. 2 weeks later, and then 2 weeks after that, his SGLT was initiated. And then eventually, SCZ was decreased to 5 grams a day, and then discontinued. So my questions for the panel here, and in addition to Robert, anybody else on the panel can ask. Now, if it wasn't due to the SCZ, remember this guy lives 2 hours or 3 hours away, so the normal providers he sees are not at my setting, right? So he's got other providers telling him what to do, and then we tell him something different, and he's conflicted on, do I trust these people that are my local providers that I see day in and day out? Do I trust the hospital system 3 hours away from home? So what's the best way to treat him? Would you have done anything different than what you saw that we did?
I mean, again, I thanks so much, Dr. Albert. If I were your personal pharmacist working with you in your clinic, my big job, honestly, is to improve, number one, availability and access, as well as appropriate utilization. One of the things that we should always consider when addressing these are looking at our social determinants of health. This gentleman's health literacy, you mentioned he's from a rural area. It doesn't mean he's just has high school education, but you still you need to assess that. You also need to know, as we've heard from Dr. Desai, as well as Dr. Green, that these agents, that once you stop them, the binders, it can be an issue, and patients are very picky about their meds. So would I have recommended to you something different? The first thing I would have done is, again, and it looks like your pharmacist did a good job, is number one is to make sure that this drug was definitely available. At my institution, Lokelma, I have pushed, as you've heard already in this conference, I pushed to get drugs on the inpatient formulary. And the reason being is it gives me time to educate the patient and to reassure them that this is an appropriate therapy for them. And I'm able to tailor that based upon their social determinants of health and their health literacy. And again, then the second aspect is exactly what you did. SGLT2s and also ARNIs now, I hate to say it, it's really interesting. ARNIs are now generic, but they're more expensive generic than they are brand, so you're gonna see that for the next year. So from that standpoint, I actually would have done exactly what you really have done from that standpoint in terms of Dr. Desai and Dr. Green talking about sequencing, making sure that that patient had access to an SGLT2. Dr. Allen and I fought to get that on our inpatient formulary. We fought renal and endocrine, and we got it. And so getting that, number one, access for that patient and understanding. And then number two, changing over to that ARNI. I would have asked you, what is this patient's healthcare coverage? That would be the thing. If it's Medicaid or VA, much different approach than that of third-party coverage. I will say third-party coverage has been so much nicer now with not only the SGLT2s and the ARNIs, but also with regards to these potassium binders.
And they are expensive.
And
It doesn't matter which one.
Expensive.
We have to know that, yeah.
But actually, Dr. Albert, I completely agree with your first step. If that didn't work, then the next would the problem is he lives so far away that if he were to have an issue, getting him to, and that's the other reason how I would have counseled him, was to say that, this drug is going to prevent you possibly from going to the emergency room, like, again, the Lokelma. And therefore being adherent to it and following up. Yes, you may have to drive in just for some blood tests, but honestly, this can keep you on your life-saving meds. If I have one more time, I wanted to kind of chime in. The other thing, too, is he was having prostate cancer. And I always want to remind people, and I learned this from my Duke colleagues, when we think of heart failure, we think of it somewhat like cancer. And when you get side effects to potentially life-saving therapies, you don't just throw the baby out with the bathwater and go, well, we're going to stop your anthracycline, we're going to stop blah, blah, blah. No, we treat through that, and we now have the ability to do that for heart failure. So why in the world would I want to drop medications that are reducing my mortality in a combination of 4 pillars for a 70% reduction? And I'm very passionate about this because my uncle lived to 95, and he was with class 4 heart failure, taken care of by a Duke cardiologist, and was on all 4 pillars. But his cardiologist in Wilson always wanted to do the identical same thing we were just talking about. And I'm like, no, 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 no. And that's when I call my peeps at Duke and they'd argue with it. But You know, honestly, as I said, I know a big answer for a very short question, but the best ways, I also would have discussed, and you and I've talked about this, about potassium, high potassium foods and those aspects. We've talked about, I've actually incorporated that into my education. I don't like to step on our dietitian's toes, but I have incorporated that as well.
Great. And we actually have a high potassium handout that we give to patients. And again, that's not going to be for everybody. It's really the combination of high potassium foods. Stopping one food, like stopping bananas, is probably not going to be enough. So it just depends on the cumulative effect of that. So in patients with high serum K, is using sacubitril/valsartan better than using an ACE inhibitor or an ARB?
I'm gonna chime in on this here.
All right, go ahead.
I'm not lying. As I said, I was very fortunate to write the editorial for one of the JACC papers where they were discussing the issues with, and I talked about this yesterday, angioedema with these switches. And actually, believe it or not, the highest, according to the FAERS database, is when you go for an ARB to an ACE. I say poop or get off the pot. So my philosophy is de novo. If you start de novo, actually, you're able to adjust the medication appropriately based on hypertension. You're lowering your risk for, as Dr. Albert mentioned already, for hyperkalemia. And number 3 is again, the 20% reduction in overall mortality and a lower risk developing angioedema. So I say de novo is the way to go. But this is where my profession comes in. Access, access, access. And that is one of the things that I try to provide for my providers. So I have like several things up my sleeve if I need to try to get a hold of one of these ARNIs. So, yes.
Got it. Go
If I
ahead.
can, just the only comment that I would add to that is that, you know, the way you phrase this is that the patient's starting with a high serum potassium, and I think it's important to remember that ARNIs are not a therapy for hyperkalemia, but they may be associated with less incident hyperkalemia, and so there's still a hyperkalemia rate, and particularly in combination with other drugs. So I think the sequencing is important, but in a patient who starts high, the potassium's got to be normalized before you would initiate the drug. And
Completely
I was just curious, when the patient that you presented, the potassium is 4.9 at the start, and you essentially embraced this strategy of using the SEC to get the MRA on board, and then you withdrew the SEC at the end. Can you talk us through a little bit that decision-making? Because in the end, it looks like you were able to maintain the patient without any
Well,
minor.
we'll talk about that
Okay,
when
great.
we get down to that. Yeah,
Sure, yeah.
because that was a problem.
Okay.
Discontinuing it. So, okay, we already asked the audience this question. By the way, I'll just mention that for sacubitril/valsartan or an ARNI versus ACE or ARB, we know that if your eGFR gets below 30, you may be more likely to have an increase in hyperkalemia if you're on ARNI. But as long as your eGFR is greater than 30, you're more likely to have a decrease in, or a lower eGFR, I mean higher eGFR, I'll get it out in English, your hyperkalemia or the potassium will not go up as high. So normal eGFR, anything above 30, you're less likely to get hyperkalemia when you're on it. It's just the really low eGFR that gets our patients into trouble. So this patient, you know, what happens at least a lot in my clinical setting is the patient comes in, they're hyperkalemic, and our provider's first thought is stop the RAASi, stop the MRA, even if they're thinking about how we're going to treat it. So should we really be in real life maintaining these drugs when we start the potassium binders? How should we really treat our patients in real world?
Well, I can chime in on this. I mean, it's really a false choice when you think I either got to have someone on GDMT or have normokalemia. You can do both. And I think the concept, first of all, Akshay mentioned that to initiate these drugs, we need to get people normokalemic. So if they're actively hyperkalemic, now is not the time to initiate RAASi and MRA therapy. But let's say someone had hyperkalemia in the past and they're normokalemic today. I mean, the bottom line is whether you want to do upfront early use of a potassium binder for prophylaxis or just start the GDMT or escalate and then know you have it in your back pocket, the bottom line is there's no excuse for not being aggressive with GDMT is the bottom line. So again, we think of this, oh, I can't use the drug because of hyperkalemia risk. I mean, again, first thing to ask, are they already on an ARNI? They should be anyway, right? It's a better drug for efficacy than ACE inhibitor and ARB. So, but this is another reason, hyperkalemia risk. They should already be on an SGLT2 inhibitor for mortality, heart failure, hospitalization prevention, but it also prevents downstream hyperkalemic risk. But again, if you're concerned that they still might not tolerate that spironolactone, just rest assured that whether you start SCC or patiromer now, or you know you have in your back pocket for later, there's no excuse for not trying MRA again. That's my take home.
All right, so now, how do you give it in real world in light of other medications?
Right.
You'll remember that Akshay showed us that if you're on patiromer, you have to have no other drugs within 3 hours on either side, otherwise you're gonna get rid of that in your stool, right? So you're getting rid of the therapies that we know are important. For
And this is where
SCC,
we
it's
come
2
in.
hours.
Yep.
So how do we do that? My
Right.
patient didn't have a lot of drugs, but my typical patient has like 20 different drugs. So
All right, so this is where, and I know as for you guys, sometimes you don't have that, you only have 20 minutes to see a patient, but I have time, so, which is great. So one of the things that I actually do, I visualize. I am like, literally, we have taken the patient's med list, and we have it laid out in terms of time. Now, I know in there it basically states, well, you can do 2 hours here or 3 hours before here. For certain meds, the issue is patients are not going to remember exactly what meds they're supposed to give before that. I always say I hate to say it, I make it simple, 3 hours before or 3 hours after those medications. And then, but scheduling it based upon their preferences. And I find that works, but that takes time, and giving a visual med grid and how to do it. But you also, it's very labor intensive. You've got to prepare it, and then I've got to schedule things around it, and I've got to schedule my life around it. But if you sell the ability to say, this drug is allowing me to get you on these pillars that are going to reduce your risk of death by up to 70%, I've sold that to many, many patients. And I actually get them, if they're not going to be engaged in their regimen, it makes it very difficult. But if they are engaged, and they understand, like Dr. Desai talked about education, I find it works. But I'm old school. I just schedule all the meds in between the 3 hours, 3 hours, because otherwise,
So we need to clone you, is what you're saying.
I'm sorry?
We need to clone you, is what I'm saying.
No, I'm just saying what I want you guys to do is to use your pharmacist within your
Yeah.
health systems. But a great example, I'm going to just go back, is like cholestipid. Remember? It's like a bile acid resin. There was a time where they said, cyclosporin doesn't interact. And I'm like, I don't think that is true at all. It's going to bind everything. It's like sandpaper. And sure enough, for those, I just schedule everything just 3 hours, 3 hours after. I make it as easy for the patient as possible. As someone who takes 4 meds, I screw up and I've forgotten my metformin a couple of times. So I understand, and I'm on 4. So, you know.
So I will agree that what I've done is taken a piece of paper and literally, if the patient has intranet, just fax it to them, send it to them, just so they could see what they need to change to make it
Exactly.
work. And remember that it may be that, I've got patients who are getting carvedilol twice a day, so I've had a few where I've changed them to the once a day 80 milligrams, and that has worked just to get them so that they can take this at a good time. And it's really only the first 2 days where you're giving it 3 times a day where it gets a little bit tough. After that, it gets much easier.
So, and in the maintenance, right, patiromer is BID and SCC is once a day. So if you're taking 4, your medicines twice a day already, then effectively you've got 4 dosing intervals with patiromer and 3 with SCC. Is that how you're doing it?
And also, I think that's one of the things with CKM as we're moving into that. I've also found that with we have so many more nephrologists that are getting that are involved, and they feel more. I don't know, but they do feel more comfortable with glaucoma, and that's because of the dosing strategy.
Makes sense. All right, we talked a little bit about counseling here. So again, we talk about who should receive K-binder therapy chronically. You could saw in our case, it wasn't me, it was another one of the physicians who saw the patient when he came back in, and they discontinued the SCZ. But I think we're learning more and more now about the need to keep it going. And again, there is a cost scenario, so we have to think about that bigger picture and what it really means to everybody. I do have one question that I didn't put up on the slide here. If clinically unstable, how do you treat hyperkalemia? You know, so most of the hyperkalemia research studies were completed in people who were stable, not unstable. I think Patrimer had some early studies, but not in heart failure. They were in chronic kidney disease that were unstable. But in heart failure, we don't really have a lot of evidence on that acute, really, you know, sick patient side. Any thoughts from the panel?
We acutely treat it. I mean, I see more from an inpatient standpoint, and again, you guys can discuss the strategies between if you're going to be shunning potassium in with insulin and versus an acute binder.
Yeah, I mean, these binders aren't treatments for emergent acute hyperkalemia. So I mean, I encourage you, you know, all the things we learn about in medical school or nursing school, you know, the calcium, the bicarb, the insulin, the glucose, all that kind of thing. So you still have a place for that, of course.
And how often should potassium levels be checked when somebody's on it chronically? Is there any rule of thumb? I mean, I just do my own thing, but I'm just curious to hear what you guys have to say.
I'd love to hear
Well,
you.
I mean, the guidelines are going to say for just MRA therapy, we should check it every 3 months or so. Just chronic maintenance, checking a basic metabolic panel. So I think the same philosophy still applies here. You know, if you're on MRA therapy, which you of course should be if you're using a potassium binder, that's one of the big reasons to use it. I say every 3 months. Pretty much every time I see a patient in clinic, a chronic stable patient, I'm usually checking blood work at that time. They're usually, again, knock on wood, already on optimal GDMT, maximally tolerated target doses. And I check BMPs, and I usually check an NT-proBNP as well, too.
Yeah, the only thing, I like that strategy, and I do think that if you elect to pursue this strategy, that Stephen's slide about the hyperkalemia, once it's happened, it's going to happen again, right? So I think that if you take a patient who's been hyperkalemic and you decide, I'm going to be aggressive with guideline-directed medical therapy on the backdrop of a potassium binder, to remember that as well-intentioned as patients are, that not everybody takes medicines as we do, and sometimes they miss doses and other things, and this is a higher risk strategy because you've taken a high-risk patient and now you're putting them on a regimen that we know, as I showed you in that run-in period, in 80% of the cases might drive the potassium into a range where you're uncomfortable. So I think it really is important for surveillance to continue in patients on the binder, and I don't know the right interval, but I'd say it's every few months probably.
So
Dr.
I
Adler,
have-
have you ever been able to get people? We have not been able to. We continue it chronically, so it was interesting just how many your experiences with getting them off of a binder.
Yeah, I haven't had a lot of experience doing that.
Yeah,
so
I mean, I hate to say it.
I was like shocked when I saw it on the thing. Now, my last question for you, I know we're out of time here, is an important one that I'm curious about because it's my pet peeve, and that is that, you know, we know that severe hyperkalemia is 6.0 milliequivalents per liter. We know hyperkalemia starts at 5.0, and we know that providers get all rattled when their potassium is 5.2. I don't get rattled till it's over 5.5. So my question for the panelists is, should I be getting rattled when it's under 5.5? In my mind, hyperkalemia is about 5.5 or higher. So I have a patient, in fact, this guy at one time was up to 5.4 again and then went back down, and I just watched it and did another, you know, talked a little bit more about diet, see if he was resuming the things getting him in trouble, and then I just got another, I waited 30 days and got another BMP. But I'm curious to hear what you guys have to say. Are we as providers just jumping too soon when we see a high potassium and automatically trying to discontinue things that we should not be discontinuing?
So from my perspective, you certainly shouldn't be discontinuing things with a potassium of 5.2. But where you should get worried, though, is if I have a potassium of 5.2 and someone's not already on MRA, not already on ARNI, and we say, well, gosh, I wish I could start these therapies, but I can't today, and I'll see you back in 6 months. That's where we can't accept that, because you're not allowed to start those therapies with potassium of 5.2. But now the onus is on us, get that potassium lower in range, and then do rapid sequence or simultaneous initiation of ARNI and MRA, knowing that you have, for example, with SCC, up to 3 times a day if you need to for 48 hours if you run into trouble. But again, be aggressive in getting people on 4 pillars for HFrEF as soon as possible. Don't let hyperkalemia get in the way.
Actually, did you have any questions that we
Yeah,
need to hit?
I do.
real
I just
quickly?
wasn't. I didn't want to interrupt your case.
Yeah.
So, but I think there is one here. I think we've gotten to some of this, but this is a really interesting question about do we have any data about the binders mitigating some of the positive effects of these therapies as opposed to just the potassium-related effects? And
they're
I mean,
pretty
I'll
safe.
what's that?
I think they're pretty safe, except for, the extra chance of edema with SEZ. And that's real, maybe 11 to 20% of patients, just depending on what's going on with them. And so we do need to look at that. And again, starting an SGLT inhibitor, if they're not already on one, may help that automatically.
Yeah, and then there's a question about frequency of potassium checks, which I think we've addressed, and then guidelines. So that's an interesting question, and you've led a number of them. So what is your speculation about how that would be?
I would imagine that in the next iteration of the guidelines, I am not on the guideline committee currently, but I would imagine they're going to be raising it just with the newer research from the RAASi case study down the road. All right, I believe we're out of time. Thank you, everybody, for sticking around with us during this lunch session. It's great to have you.